Hi, well, welcome to this segment of Heart Success, making inroads and improvements in heart failure. I'm joined by Carolyn Lam, a world's expert in heart failure. Welcome, Carolyn.
Thank you so much. By the way, love that term, heart success. And I can tell you that patients really appreciate that as well.
Yeah, when you hear the word heart failure, it sounds like, such a downer. I mean, we've got to elevate people's spirits. We've got to turn the corner in that language, don't you think?
Yeah, it was really insightful of you to bring that up. I mean, I literally had a patient bring that up to me spontaneously a couple of weeks ago. And I was immediately reminded of what you said. And it's true. Sometimes I think when we're educated in this, we forget what it actually implies. And you're so right. So here we are talking about heart success,
Heart
and what better
success.
time when we truly do have a bonanza of treatments for heart failure reduced ejection fraction.
Exactly. I mean, we've had a lot of heart success. And I think
Yeah.
for a person like me who's not a heart failure doctor, I mean, I take care of heart failure patients. I want to hear from you. How do we organize all this? I mean, here we have all these great choices. Some people are saying just start them all at once. Now, I'm a pretty aggressive interventional cardiologist. Even that sounds a little scary to me. Or then you could kind of add them one on top of each other. So, what's your view of things, Carolyn? How should we put all this great success stories together?
Oh, Mike, you're so insightful. That is exactly the stuff that's really circling in the failure circles now. Heart success, maybe. And
Heart success
everybody's
circles.
waiting. Everybody's waiting with a bated breath of what formal guidelines are going to say, but lots has been written about how do we prioritize, how do we sequence, do we still do what we used to do? So, kind of long story short, we used to kind of go, all right, we'll start with the ACE inhibitors, we'll titrate them up, then we'll add the beta blockers, we'll titrate them up, then we'll see if they need MRAs. So very sequential and up titration and so on. Now, problem is, it takes forever.
Hmm.
So it takes months before you get a patient to go therapy. And people get lazy along the way and it doesn't happen. And we've got tons of cohort data from around the world showing we're just not treating patients right. And that's just with ACE inhibitor, beta blocker, and MRAs.
Right.
Now, just in the last few years, right?
Yeah.
First, we had ARNIs that completely shook us up. And
Mhm.
that you can see it as adding neprilysin inhibitor to an ARB or see it as replacing the ACE. And then we got the SGLT2 inhibitors, not just one, but two, so it may be a class
Right.
effect. And so everyone's talking about these four foundational therapies now of ARNI, beta blocker, MRA, SGLT2 inhibitor. And the trend, if I may, so far is to sort of say, listen, we need to get off our laurels. We need to recognize that this is a really difficult, I don't want to use negative words now. I mean, a serious condition that's got a prognosis that actually rivals some cancers.
Right.
And if in cancer we know how to start multiple therapies at the same time and go hard, why don't we have at least a little bit more urgency with heart failure and therefore start or aim to get everybody on these medications as fast as possible?
Right. Right.
Just do it straight away. Now, there is scientific rationale for this as well. First of all, multiple sub-studies have shown that the benefits are additive.
Right.
Secondly, some medications actually help deal with the side effects of the others, right? Like you get
Mhm.
less hyperkalemia when you use ARNI, you get less problems with MRAs, or you get more ability to use MRAs when you have SGLT2 inhibitors. All these data are coming out, so their benefits are additive. And finally, the benefits are realized really early,
Yes.
within the first 30 days for most of these medications. So we're like constantly depriving patients of this early benefit if we keep pushing it out.
Right.
So this is kind of the trend.
It's
I
starting to
think
sound like you're a start 'em all at once kind of person.
I am, and you know what? Frankly, I'm a be a bit simplistic about it. So now I just go in. I know there's a target to get them on the four. Just do my best to get on all four, and don't dilly dally about it. Don't give excuses about it. Just do it. Now, the nuance comes in which to start first, exactly which, all four. I do think there's room to be sort of very to individualize that kind of therapy. What I would say, for example, if the blood pressure is very very borderline, you're not going to start Arnie.
Right.
You might start something like an SGLT2 inhibitor.
Right.
If the
Right.
heart is racing away, you might immediately start the beta blocker first if the patient is, of course, not in overt decompensation, and things like that. So then you just take it focused on that individual patient. Just keep it simple like that, I think.
That all sounds
Is that
great. I mean,
okay?
do you do all that as an outpatient, or do you try and get all this done as an inpatient?
Oh, that's a very, very good point as well. I think we need to recognize the hospitalization episode as an opportunity to up titrate medications, not just an occasion to diurese the patient, not just get water out, but actually push up meds while they're being monitored in the hospital, and then of course continue to do so in the outpatient clinic. But we're all limited by the number of clinic spaces and
Sure.
patients that we can see and so on. So I think a hospitalization episode is really a chance to do as much as we can and to continue doing that as an outpatient as well.
Now, would there be any role for an observation unit? Not a full hospitalization, but an observation unit kind of thing for a day or two just to see how someone's doing when you start all these things together? Again, I'm an interventional cardiologist, but it sounds like a
A
lot.
very smart one.
Yeah, a very hesitant one.
Absolutely, yes. But in this COVID pandemic, I see a
I see.
lot of opportunity for mobile,
I see.
home based
Yeah,
up
that's a
titration,
good point.
things like that, telehealth, which I really think we should harness a bit better to get therapies optimized.
Now, how's COVID going in Singapore? I've got my two shots. I did, I think I
You've
had
been
COVID.
all over about giving people shots
And I've been
too.
giving people shots. If I see an arm, I'm going to give someone a shot. And, I felt fine. I mean, maybe it's because I got so sick back last February that when I got the shot, my body said, oh, this is nothing, just a small flesh wound. I mean, how are you doing in Singapore? You know, I saw that there have been some waves. Where are you at this point?
We're doing well, but before I even go on, I just really want to thank you, Mike. Thank you
Well, it was
for
my
what you're
son.
doing, for the
He
example that you're setting. Here, okay, so COVID's under control, and we're really, really fortunate. We have a very obedient population too. Everybody wears masks everywhere.
wow.
It's sort of become a way of life.
We are very
And
disobedient in the United States.
I didn't say that, but okay, you did.
Oh, we are.
Right.
We're
And
independent.
so
We're
that
very
that really
independent, Carolyn. That's the right word. We're very independent.
That's a good point. But strangely enough, when it comes to vaccination, so we have started vaccinating people. We've got a very efficient, beautiful government and ministry who's made sure we've got vaccines for everyone free and so on. However, people are hesitating. So,
Really?
and it's because it's completely voluntary at this stage. So it's an interesting phenomenon. We don't have the problem of shortage. We have a problem of being really organized about it, and yet people have fears and misconceptions, perhaps. And
Sure.
so, again, I wanted to thank you for what you're doing. I really
Well, I
hats
hope
off to
though
you.
when Singapore opens its borders more, there are going to be people coming in, and I hope that's when you
Yeah,
have.
we need you to come help.
Yeah, I'm glad to come over. When you had your kind of second wave, I think it was when all the people returned to Singapore from being
Yeah,
abroad, right? So
yeah.
It's probably good to plan ahead for people returning to or coming into your country to get vaccinated. But I can understand
Yes,
some of
that's
this.
that's exactly what's been said here. Like, don't take our peacetime for granted. Now is a time where we can be very, organized and calm about the vaccination to do it before
Right.
something happens. Yeah.
Carolyn, thanks for joining us today. Thanks for all your success with your heart failure patients. And I look forward to chatting with you on our next episode.
Absolutely. Thank you, Mike.
Bye bye.